welcome back to EASD Miss China Daily Highlights. With great honor, I have Dr. Jackie Sturt with us today to share the assessment and management of diabetes distress at EASD, which the first clinical practice guideline published. Professor Sturt, warm welcome.
Thank you.
Thank you very much.
Lovely to be here.
Thank you. So, Professor, how does diabetes distress differ from depression or anxiety? And why is it so important to address this in people with diabetes?
Yeah, this is a common question as people become more and more familiar with diabetes distress. Diabetes distress is normal. So people, when they live with diabetes, they have an emotional burden. It's a bit overwhelming from time to time. In fact, it's a lot overwhelming from time to time. And so the stress related to it, the de-stress, does fluctuate, and it goes up and down according to different transitions in time, treatments, changes if a woman becomes pregnant, or they change where they have their diabetes clinic, or those kind of transitions. It fluctuates. But all those fluctuations are normal, and we have temporary rises, and then it goes back down to being okay. But for some people, the diabetes distress just persists, and that's when it becomes more problematic. And it differs from depression and anxiety because those conditions are diagnosable mental health conditions. There are DSM criteria around those diagnosable conditions, and they are abnormal. So we don't want people to be living with depression and anxiety. They're abnormal and they're treatable. Diabetes distress is normal, but it fluctuates. And when it gets persistently high, then the sort of consequences that it leads to is people become so overwhelmed with those daily management, weekly, yearly management activities that it stops them being able to it sort of arrests them from being able to carry out the self-care behaviours that are necessary for their good health. It stops them from being able to contemplate going to appointments. It stops people from being able to do the right amount of monitoring that it's recommended. They might not be able to administer enough insulin as they would be healthy for them, and make decisions that they would otherwise make around nutrition or around physical activity. And when all these things kind of stop, then obviously the risks of complications, hyperglycemia occurs, and that becomes problematic for the physical health of diabetes. So that's how the mental and the physical health really come together through diabetes distress.
Thank you very much, Professor, for your very clear sharing. I think that also explains why EASD published this first clinical practice guideline, right? Part of the reason, at least. So the following question is, we want to ask you to help us to understand what key studies or findings that led EASD to develop this first clinical practice guideline on diabetes distress. Can you help us to elaborate
Yes,
it? Thank you.
Yes, of course. So I would say that there were sort of three bodies of work really that have been really influential. There's increasing amounts of evidence, but the work of Larry Fisher at UCSF, University of California, San Francisco, he and his team have done a huge amount of work going back decades to first identify diabetes distress with his colleague Bill Polonsky, and then increasingly get better at measuring it, so that we know how much distress and what the cut-offs are and what the sources of distress are. His work has been about assessment, and then it's sort of increased into interventions and different types of interventions. The second group really the second piece of work is the Diabetes Miles study in Australia from the Australian Centre for Behavioural Research in Diabetes and Deakin University, and they did that first big piece of prevalence research
Yeah.
to really show that how many people are experiencing diabetes distress at any one time, and the figures are, sort of about 1 in 4 people in any clinic will have elevated diabetes distress.
Yeah.
And then over the last few years, there have been a number of systematic reviews.
Yeah.
So as the topic has got into the consciousness of the diabetes community, there have been a number of systematic reviews and meta-analyses, starting with my own. I published the first meta-analyses in 2015, and the work of Andreas Schmidt and colleagues, and Chu and Perrin, have really sort of gone into greater specific detail, looking at particular types of interventions, particular populations, really concluding with this significant body of evidence that has led the EASD and its membership to say, well, this, now we need a guideline to help clinicians to know what to do.
So thank you. You gave us like a thorough storyline of this, the development of this guideline. So now, can you help us to explain or to share with us the specific recommendation in this guideline for assessing diabetes distress and for intervention and management strategies for diabetes distress?
Yes. Yeah, so the guideline covers both the assessment of diabetes distress, as you said, and the management. So I'll start with the assessment. We've developed, from my own research in the UK, the de-stress study, we've developed 8 good practice guidelines for the assessment of diabetes distress in routine clinical care. And that really starts at the point, like the first guidance is, think about this at the beginning of your clinic. As a healthcare professional, you're about to go into your morning clinic, your afternoon clinic, and having objectives around, you're going to have an emotional conversation, or you're going to inquire about someone's emotional health. Every patient that you see that morning, or that you're going to ask them how they are feeling about their diabetes, what's bothering them the most about their diabetes at the moment, and that's the guideline. That's the first recommendation is that we do that at every consultation, and the other recommendations really go through the consultation. So we're thinking about when we're asking about emotional health, do it with curiosity, ask open questions with that curiosity. When you and use a validated tool to assess it. So we've got a number of diabetes distress scales that can be used: the PAID, the DDS, the DDAS. They all have come from the work of Larry Fisher and his colleagues I mentioned a moment ago. So they are really good tools, and we recommend using those tools. And those tools serve several purposes, and these are all subsequent recommendations. They raise the consciousness of the person with diabetes around their own emotional health. So they enable them to say things out loud. It stops people from ruminating. They think, they record it, and then they're invited to have a discussion with their health professional, and that helps them to get it out into the open and start to have kind of light bulb moments about what they can do. And then it also helps the healthcare professional, assists them significantly in working out what they need to do in the follow-up. Does this person need intervention? What follow-up should there be? Is that follow-up something quite significant? Or is it a phone call or an email in a couple of weeks' time? But follow-up is really important. And then the last 2 recommendations are around recording this in the clinical notes. So whatever the diabetes distress score is, record it, because that ensures that a number of things. You can communicate that with colleagues. Continuity of care is developed, even if continuity of carer is not there. At least it's in the record for the next person to come along. And also it enables the diabetes distress to be tracked over time to see whether or not is this person's distress going up, is it going down, is it staying the same, and that will inform your clinical decision making. And then finally, from the healthcare professional's perspective, this assessment process allows them to think, do I have all the skills and the knowledge to do this? So that they can then think, well, maybe I need to do a little bit of professional development in this area. Maybe I need to talk to colleagues to understand what are the care pathways. If one of my patients has more severe or challenging psychological needs, then and it's I no longer have the skills to. As a nurse, for example, to be able to support this, then I might need to find out where the psychological team is, or and refer on. So it's about signposting those as well.
Beautiful.
Moving on to the management, which was your next question. That's a simpler answer. We have recommendations for type 1 diabetes, for the management, and for type 2. For both type 1 and type 2 diabetes, the management question around psychological intervention being effective is the same. So we know that psychological interventions such as cognitive behaviour therapies, such as motivational interviewing, those are really good therapies. For people with type 2, diabetes education or psychoeducation is also a recommendation, that we know that that's effective in helping to reduce diabetes distress. And for people with type 1, we know that the use of continuous glucose monitoring reduces diabetes distress compared to finger pricks. So those are the kind of management recommendations that we're highlighting.
Thank you. I think you shared beautifully with these recommendations and how it can help, as you just mentioned, clinical physicians in better recognize and manage diabetes distress in their patients, which is very important, because at my interviews with different experts, clinicians, they are all mentioned to me they want tools, right? They want in their toolbox, they need more tools, and I think we now have this exciting and very useful tool. So if I may to ask you to summarize, you already mentioned a lot. So in which way it will help clinical physicians in better recognize and manage diabetes distress in their patients with this guideline? And how do you envisage this guideline? So in the future, what a difference it will make in clinical practice?
Yes. Well, guidelines take time to be fully implemented, that's for sure. It ultimately will make a very big difference to people with diabetes, and as a consequence, it will make a difference to healthcare professionals who are working with them, because when healthcare professionals start to implement some of the recommendations, they will notice a change in their patients. And when you notice a change, you see the patient having that light bulb moment and being able to talk about something that they've never talked about before. It helps them to really understand their own challenge and to make steps to resolving it. And you will witness that as a healthcare professional. My personal recommendation would be to start with the assessment. If you want to start somewhere, I'm a behavioural scientist, so I'm thinking behaviours. We've got 8 recommendations here. Have a look at the good practice statements. Have a look at those and think which are the quick wins in this list. Which am I almost doing? Which could I just make a little bit of a tweak to my practice and start to do regularly, routinely, with kind of mindful thought. And as you start with 1 or 2, implementing 1 or 2, then you will see a difference, and that will be motivating for you to think, oh, okay, so I better write this down, or I better develop a follow-up plan, or maybe I need some more training and I'll go away and see where I can upskill myself. So take a step-by-step approach in your own clinical practice, and you will see a difference.
Okay, so now I would like to conclude today's interview with Professor Sturt in helping us to better understand this first EASD clinical guideline on diabetes distress management. As Professor just mentioned, guidelines translate into practice takes time. So colleagues, then let's hope for the future so we can have this guideline plays more important role in our daily work. With this, I would like to thank you very much for your time and attention. Thank you, Professor. Thank you.
Thank you.
Bye-bye.
Bye-bye.